pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. First item on the agenda is public comment. Do we have any comments from the public? Hearing none, okay. Next item is the consent agenda. There's the regular minutes from the last meeting, and of course we got the calendar filled out as well as we can. Do we have a motion?
I'll move that we approve the consent agenda. I second.
Okay, moved and seconded. All those in favor?
Aye.
Passes. Okay. Now we got the hot topic, the audited financials.
So we're going to connect into Zoom or Microsoft Teams. And you should be able to hear and see Eric without a problem. You can see.
Impressive so far.
Eric looks kind of weird.
Eric, can you hear us?
I can. Can you hear me?
We can, we just can't see. And then we're going to give you the,
You don't need to share this.
we don't share?
They're gonna show, they're gonna share.
Okay, so Eric, you're going to share your screen.
No.
Sounds good. I've got Dave Imus on the line with me too, senior manager.
Okay. So you are in our board meeting, and we would like to ask you to make your presentation on our audited financials.
All right. So yeah, if we're ready to go right now, we can definitely do that.
Okay, fire away.
Well, thanks for having us. It'd be nice to be there in person maybe next year. But we're ready to go over the results of the 21 audit. And I have with me Dave Imus, who is the senior manager on the job. And he is going to throw his screen up here in just a second. And we can start the audit presentation. And then as a follow-up, I can go over the cost report results as well.
Okay, good, excellent.
Everyone can hear okay?
Yes.
Okay. All right, Dave, take it away.
Thanks, Eric. So for those of you who don't know me, I'm Dave Imus. I'm the senior manager here at Volte. I work really closely with Eric and also with the team at Lake District on the audit every year. So for those of you who have been through similar presentations before, we prepared a lot of the same information, or similar types of information at least. We're going to take you through a summary of required communications that generally accepted accounting standards require us to communicate with you. We're going to go through the financial statements in kind of a condensed format. We put together a little bit of ratio analysis and some benchmarking to kind of see where the district is at. And also, I put together a really, really brief accounting standards update. Spoiler alert, it's only one new accounting standard that I'm updating here. So getting right into it, starting out with required communications. So this whole section that I'm going to be talking about summarizes what was given to you in what we call the required communications letter, or the governance communication letter. They're all the same thing, but they meet our professional standard in communicating to the governing board the matters that we're going to go over. And I'm just going to kind of hit the high points since you guys have that in the formal letter. We talk about our responsibility, which is to express an opinion on the financial statements in accordance with GAAP, and to design our procedures that we use in doing so, to provide reasonable assurance, not absolute assurance, that the financial statements are not materially misstated. A note on that, during our audit, we're required to consider your internal controls for the purpose of determining our audit procedures, but we don't give any assurance on our internal controls. What you won't see from us is a report that says anything to the effect of internal controls are in place and operating effectively, because our procedures simply weren't designed to do that. We weren't engaged to do that. But if we do see a breakdown in internal controls that merits your attention, we'll definitely bring that to your attention. So, kind of an easy way to put that is, we're not necessarily looking to give an opinion over internal controls, but if we see something, we'll say something. That's our responsibility in that area. We issued an unmodified opinion on the financial statements. I think it's dated February 22nd. And we're also responsible for the communications that we're going over right now, and then we gave you a required communications letter. Significant accounting policies. It's important to know that the management's responsible for determining their own accounting policies. And those are summarized in the notes to the financial statement in note 1. So if you want to see, for example, how the district considers cash and cash equivalents, you would be able to see that in those notes for anything that's rather big on the financial statements. We didn't note any transactions for which there was lack of authoritative guidance or consensus in the accounting world. And there weren't any major new accounting policies that management adopted during 2021. Accounting estimates are important to all hospitals and rural hospitals, critical access hospitals in particular. That's because of how the revenue cycle works and how that interacts with the financial statements. So all the allowances that flow through those line items having to do with revenue and receivables, those are all considered significant estimates because they're how we get those numbers is dependent on a number that maybe wasn't fundamentally knowable at the year-end date, which is June 30th. Also, third-party settlements, because those are subject to various levels of review after the cost report is filed. That's considered a significant accounting estimate, even though that number is based on a number that came from a filed cost report, which we helped prepare. And then a newer one is the amount of funding that was recognized as revenue in the financial statements as a result of the CARES Act. So that's like the provider relief grant and that sort of thing. We consider that a significant estimate because for a couple reasons. One, it requires management to estimate how much lost revenue would be. That's a significant estimate because you can't really go back and find out definitively how much lost revenue, how much revenue would have been had there not been the global health crisis. And also, we consider a significant accounting estimate just because the guidance in this area, ever since it came out, has been so fluid that if it changes in the future, considering an estimate would give us the ability to make corrections to it prospectively and not have to reopen past years. So what do we do as auditors with those estimates? Since we can't pin them down to like a cash basis transaction necessarily, we evaluate the factors and assumptions that are determined to kind of model those and determine if they're reasonable in the circumstances. Management representations, that is attached to the required communications letter. You'll find a list of a letter that contains all these representations that management makes to us, confirming their responsibility for the financial statements. Beyond that, we didn't encounter any significant difficulties in our interactions with management, and there weren't anything. There's nothing else that really gives us pause or worry that we need to communicate with you. So that summarizes at a fairly high level the contents of the required communications letter, or like I said, sometimes called the governance communication letter. It means the same thing. Now I'm going to take you through just the basic condensed version of the basic financial statements, which is the balance sheet and income statement. So starting with the asset side of the balance sheet here, you can see a little bit of a drop off from 2020 in total assets. A big chunk of that is less cash reserves on hand. The very top line here. Not sure if you can see my cursor, but the reason is because at the end of 2020, a lot of the CARES Act provider relief money was in the door but not yet spent. So the district was rather flush. But as those expenses came due and those cash inflows were shut off, we see this a lot where the 2021 cash position wasn't quite as strong, kind of coming back to earth a little bit. So still on the balance sheet, but looking at the liabilities in that position. So that position in our world is pretty much the same as equity. This is the countervailing side of the balance sheet. You can see that the current portion of long-term debt increased a little bit. That's purely because of how when the Medicare refundable advances became due. So those are included in the liabilities, and Medicare is literally netting those payments, those advances against future payments. And so as more time passes, that liability falls off. But like most other liabilities, it has a maturity schedule. So a lot of those liabilities found their way up, came up from non-current last year to current this year. So it's nothing that requires an actual cash outflow in 2021. But that's, if you're wondering, that's why that line item jumped so much. And I think that audited financial statements have this broken out in a little bit greater details. The users of the financial statements can see that a little bit clearly. So looking at earnings now, that concludes the balance sheet. We're now looking at the earnings, the statement, revenue, expenses, and changes in that position, or the income statement. So you can see that the lockdowns were pretty much isolated in 2020. You can see 2021 overall that patient service revenue bounced back a little bit, predictably so. But you can see down below in expenses, there's a little bit of a give back there in salaries and wages because of upward pressure, FTE counts, salary increases, all that sort of thing, flowing through expenses there. So more revenue, but then also more expenses. And you can also, and then bottom line down here, as you can see, there was about a $4.2 million decrease in that position, including both operating and non-operating types of revenue and expenses. So we've been through basic financial statements now and kind of looked at the high points. Now what we're going to do is we're going to show you some bar graphs that visually depict, compared to a couple of different benchmarks, they kind of some of the key financial indicators affecting Lake District. And what you're going to see, actually as you see on the next slide here, is the bars in blue, that's us, that's Lake District. And then the orange there, gold, yellow, a little bit colorblind. That comes from, that's a benchmark of similar sized critical access hospitals in the Western United States, and the green is Oregon peers. So there is a little bit of imperfection with these numbers here because the data that drives these amounts comes from filed cost reports. And so there's a little bit of a lag time and when these come in the door and get calculated, how the benchmarks come together. But they're still kind of useful, just kind of just knowing that there is kind of a little bit of a, especially in 2020, 2021, because of the delays in getting cost reports out. So we talked a little bit about, when we were talking about the income statement, how there was an operating loss and there was a decrease in net income. And you see that flowing through this chart here with 12.9%, a negative 12.9% operating margin. So that's operating expenses exceeding operating revenue by that margin. Total margin is another profitability margin, which is similar to operating margin, but instead of just looking at operating income and expenses, it takes into account non-operating income and expenses. And there's a little bit of a give back there. You can see it popped up 1.5% to negative 11.4%, so negative 12.9%, but not enough to bring it up into the positive territory there. So total margin also negative. Days cash on hand is a really important one, and this is a metric that I understand a lot of lenders put a lot of stock in. So this is the theoretical number of days that the district can survive at current expense levels with the current cash reserves. So as you can see, this is kind of the phenomenon that I was describing when I was talking about the balance sheet, where at the end of 2020, the district is really flush with cash, over 220 days, more than two-thirds of a year of cash on hand. And then you see that came a little bit more down to earth in 2021, and with 160 days, which is still a really strong cash position. So still a really, really good place to be in terms of cash reserves. And then what you're seeing here in the benchmarks too is a little bit of that timing anomaly that I described, where 2021 is down here close to 2019, right around 37 and a half days for the critical access benchmark, and 29 to 36 days for the Oregon benchmark, and then it jumps up in 2021 for both benchmarks. I think what that is a lot of the 2020 reporting actually coming through 2021 because of when the cost reports are filed. Because a lot of the facilities in your peer group were also in the same position you were at the end of 2020 with a lot more cash on hand. So this is one where the benchmarks maybe aren't quite as reliable as they could be because of the timing and some of the weirdness revolving around when the cost reports were filed for fiscal year end 2020. But the big takeaway from this slide is really strong cash position for 2 consecutive years, head and shoulders above your peer group in that area. Date of revenue and accounts receivable. This is one that measures how effective you are at turning around those patient receivables into revenue in the door. So this is one where we actually want to see lower numbers because you want the fewest possible days in AR. And we saw a little bit of a spike in 2021, but I think it was kind of a one-year anomaly having to do with the software conversion. So I think the expectation is that'll fall back down and come back a little bit more in line in future years. And then finally, average payment period. This is just a measure of how often you can turn over your accounts payable, and it's how often you're paying your vendors. So you can see not much change compared to the prior year. And then again, you see in your peer group there a big jump in 2021. That's because a lot of those deferred liabilities that resulted as a result of the CARES Act receipts, they were still sitting on the balance sheet at the end of 2020. I think the source that we get this data from, I think they were including those liabilities in with AP, whereas in our number here, we carved those out because those don't represent a future cash outlay. So that's it for the ratio analysis. And as promised, I'm going to take you through an accounting standards update. So the accounting standards is the set of rules that comes from the Governmental Accounting Standards Board, which is the standard setting body that prescribes United States generally accepted accounting principles that these financial statements are prepared on. And there's a few of them, a few more than just one, but I really only wanted to talk to you about one because there's only one that really has major future impact on the district, and that has to do with the new lease standard. So the old lease model of being able to expense certain lease payments is going away. So it used to be the case that if you leased an asset, even for a committed period of more than a year, you could expense those payments as if you're renting the asset. There'd be no asset recognized on the balance sheet. There'd be no liability on the balance sheet. It would just simply be cash outlays in every year with a recognition of expense. That reporting model is going away, and what's replacing it is a model that's going to require any of these lease agreements, such as lease for building space or you name it, is going to have to be capitalized, and it's going to result in the recognition of both the long-term liability and the right-of-use asset for both sides of that equation. So the result is not going to be an erosion of your net position or any sort of we don't expect to have to reopen prior year equity and restate. But it's gonna gross up both sides of the balance sheet, which is important because it's going to potentially impact some of those ratios we just talked about, specifically like the current ratio. It's gonna go down, that sort of thing. There are also going to be a lot of required disclosures that we're gonna have to be aware of to make sure that the notes to the financial statements in the future comply with GAAP. So there's really a lot of complexity to this new standard. Whitley in general, and me in particular, have spent a lot of time researching this particular accounting standard, so we feel like we're really, really well positioned to help Lake District with this transition to this new standard in next year. With any leases that are currently being recorded this way or ones that we need to pick up and capitalize. So, we have a lot of different options for what that assistance looks like and that sort of thing. But the big takeaway for this body should be that, we're definitely here to help. We have the bandwidth to help the district in that way. So with that, that's all I prepared that has to do with the audited financial statements. Eric wanted to share some thoughts on the cost report. I didn't know if we wanted to talk about if the group had questions now on the audited financial statements, or they have questions on the cost report, ask questions on the financial statements and cost report later. But I think I speak for Eric, and we're pretty flexible when we field those questions, if any.
I have a question on the audited financial statement.
Sure.
So I see in the back here you have the adjusting journal entries from our book income to going through your review and the associated changes. And they were pretty significant, change of 3.1 million. I was wondering if you might give us a little color on what were the main areas you found necessary to make adjusting entries, and your thoughts on that.
Yeah, absolutely. Let me just pull up, I've got a copy of that adjusting journal entry report. As you can probably imagine, we go, as part of our profession, we go through a lot of these with a lot of different clients, so just kind of refreshing my memory here.
Hey, Dave, just a quick note, I'll cover the cost report adjustment when I pull up my spreadsheet here in a second, so
Okay.
I'll cover that one.
Yeah, so some of the, some of these larger adjustments that you'll find on this schedule are related to the Medicare cost report, and it's management's practice to basically leave the books unadjusted until that report is filed, and then it comes through as kind of a post-close increase. So that's one of them. I sure can.
Eric, we've been doing that now all along, haven't we?
Yeah.
But those were not that Medicare cost report was not our biggest adjustment.
No, that was some of the bigger ones.
But there was offsetting ones there. So
Yeah, I think one of the bigger ones here, I'm now sharing the adjusting journal report. The amounts, some of the intercompany accounts, we're not eliminating. And so there were some adjustments necessary to get those accounts to eliminate properly, because there's, along with the hospital, there's other entities included in the financial report. So the due from amounts have to zero out, because otherwise, it results in a net payable or a net receivable, which is impossible.
So is there some advice you have for us in the future, so we don't see such big swings, how we might reconcile that so we don't have this going forward, these big adjustments?
That's a great question. I think our recommendation is that, before, as part of the overall year-end close process, but perhaps as a part of the monthly close process, which is a little bit softer process, I think it's a great recommendation from us to go through and reconcile things like intercompany accounts and that sort of thing, to make sure that they balance out and everything is recorded according to GAAP metrics before us, the auditors, receive the financial information to do our job. Because after we get it, then if we identify an adjusting journal entry then it puts us in a position where, we have to evaluate that for a potential control deficiency.
Okay, thank you.
You're welcome.
Any other questions? Why don't we go ahead? Eric?
Are you guys ready to go over the?
Yeah, we're ready to go on, move on, yes.
Okay, sounds good. I'm going to share my screen here. All right, so we all know how the cost report works. It's a big component of how you guys get paid throughout the year and also how you settle up at the end of the year. And it's really broken up into 4 different service areas: inpatient, outpatient, your swing beds, and your clinic. We have 2 clinics, 2 rural health clinics. And so, we're wondering, well, how did we end up with a payable this year when last year we had such a large receivable? And one thing you have to keep in mind is that Medicare is really paying you on a cost per unit. So if your units decreased one year, let's say in 2020, and then increased the next year, your cost per unit decreased. And if you're getting paid based on the prior year, it means there's probably going to be a payback. So we know that we saw utilization drops in 20, and because of that, there was a $2.3 million receivable with the 2020 filed cost report. And once that cost report's filed, your rates are adjusted later on in that year, and you're basically getting paid in 2021 based on your 2020 results. So when utilization starts to creep up again, and you start getting paid based on an old rate that was based on fewer units, you can pretty much bet probably be something that needs to be paid back. So what did we see change from 2020 to 2021? By February of 21, we saw expenses increase by 10%. Okay, expenses increase, that means we should expect to see a receivable for Medicare. But then we saw patient days, your units, increase by 22.66%. So more units, lower cost per unit, outpacing your expenses. That means you probably owe something back. Revenues, another measure of units, and that increased by 12.33%. So based on where you were at 2020, Medicare said, okay, based on those rates and utilization, we'll pay you $1.164 million. We really only should have been paid about $865,000. So that delta was about a $300,000 payback that was known about by end of February 21. So what happened between February and the end of the fiscal year 6/30/2021? We went back and looked at your expenses. They held pretty consistent from where they were at. We looked at gross revenue, that increased a few percentage points, which would also indicate payable, more units. But the thing that really changed was that your inpatient days picked up quite a bit more. They didn't stay on pace, that 22.66% increase from last year that jumped up all the way to nearly 42%. So that triggered a larger payback overall in the inpatient and swing bed area, around $800,000. So that's how you landed where you did with the 2021 cost report. I'll also mention it could have been a lot larger payback, not for the pandemic labor within provider-based health clinics. Generally, those rates are capped based on productivity standards for both physicians and mid-levels. And if that was the case, we would have been held around $328 per visit within the main clinic. Then in the Goose Lake Clinic, about $180. With the waiver, it was $570, and then $394 for the Goose Lake Clinic. So that helped reduce that payable by $465,000. So that was a big help to have that waiver in place. And the waiver could really be beneficial if your capped rate, which is something new for Medicare purposes, the clinics will be set upon. So traditionally, whatever your cost was in the clinic, that would be what your rate would be set up the next year. But last year they changed it, and now there's a cap. So the cap could be set at 328, the main clinic, but I'm hoping due to the waiver, it'll actually be set to 570. That gives you more room between whatever lower cap has been and your actual cost. So we don't know how it's going to work out, but the fact that you have that waiver in place, not only was it beneficial for the year of filing the cost report, it can be very beneficial going forward, depending on how that cap is out within Medicare.
Is the waiver still in place now?
It was in place for 2021, but then the cap kicked in April 1st, 2021. So we got the waiver through April of 21, and then the cap kicked in. And we're hoping the cap was this higher amount. We don't know for sure because that part of the rule hasn't been defined. And so you enter the cap amount in there and the remaining couple of months after that. So now on, when we file a cost report, there'll be a cap out there based on 2020 cost. Hopefully it's with the waiver, interest cost. And then you get an economic index percentage increase, very small, like 1 or 2% each year on top of that. And that's the most you can get. So let's say that the actual cost of that per visit, then that will be your rate for that year. If the following it's more than whatever the original base was, you can only get paid up to whatever that base was.
Makes it hard to run a business when we remember the rules till after the fact.
Yeah, and that was really upsetting because nobody saw it coming. And how they sold it was the freestanding clinics always had it at like $98 per visit. And that was an up event. And what this did was allow them to get a maximum rate of 190, but it took away the full cost-based reimbursement for the provider-based clinics like you guys have. There's plenty of associations fighting against it. I don't see it changing for a while.
Why is there such a large difference between the two clinics, clinic 1 and 2?
One is just a large difference in the way that you're paid the amount.
Eric, can you comment what impact this will have on our Medicaid reimbursement rates?
So far, none. So for Medicaid purposes, they pay you a cost per visit, just like Medicare does. But they set it once, and they keep paying you that rate with an economic percentage increase. But if something changes, you can file for what's called a change in scope and have that rate adjusted again based on cost. So Medicaid's sticking with that process, still based on cost. You can get it adjusted again based on cost if there's a reason to do so. But so far, in your state, Medicaid hasn't followed suit for what Medicare is doing, which is a good thing, right?
Thank you.
Certainly.
Clear as mud, yeah.
There is no.
Welcome
Let's just say
to
it's being paid based on cost for Medicare and Medicaid for most things, unless they decide to get it happen. That's what they did here.
But they do it after the fact. But for the whole year, they don't even know what the rules are.
So we're talking about going to a monthly adjustment.
Eric, going forward, do you have any thoughts on what we ought to, from a board standpoint, that they ought to be looking at or be concerned with what we're doing?
Well, I mean, the biggest concern for everyone, it's very relevant on your income statement, is the constant inflation or expense increases that we're seeing. I mean, it's true everywhere, especially for healthcare and nursing and bringing in any locum. It's getting so expensive. And we know that if we're cost-based reimbursed, and that makes up 70% of our business, well, that's great for 70%, but there's still that delta that needs to be covered with insurance payers. So you have to keep an eye on those expense increases, realizing that there's always an amount that's not gonna be cost-based reimbursement, and are your commercial payers able to cover that difference? Most likely not completely, but that's why you have, tax revenue.
You say that Medicare and Medicaid are about 70% of our budget?
Is an estimate for most rural hospitals. I don't have your guys' figures in front of you, but I would think between Medicare, Medicaid managed care, of course, it should be around, I would think, 65 to 70%.
It's pretty close.
Okay, thank you.
Certainly.
Any other questions?
Okay, is there anything else you want to fill us in on?
Nothing shocking like the RHC cap. No other updates like that. Dave, do you have anything?
We talked about the new lease standard, which is kind of, I think, giving us heartburn on the financial statement side.
Can you run a budget for us going forward next year so we don't have to? Just joking.
Yeah. One thing I would keep an eye out for is, we're still trying to work our way through all the provider funding and staying on top of the different phases of reporting, and also, like Charlie going through the PPP loan forgiveness process. So there's still those literary items to deal with, and that's going to be in place for the next couple of years.
Lines on it.
So what that means is for the grants that we've received, there's going to be they're going to have to double check to make sure we spent the money according to those grants.
Okay, well, thank you very much. I think unless there's any further questions, we appreciate your presentation, and we've got some homework to go through to digest what you told us. Thank you very much.
Thank you.
Thanks, we appreciate our ongoing partnership with Lake District.
Eric, one last question before you leave. We've struggled for the last several years to have our audited financials available within the time frame that our bank has requested. Is there anything we can do to facilitate this process moving along quicker?
Yeah, the main thing we always stress is that before we arrive on site or start the audit, that absolutely everything has to be done. We understand that the cost for it's not going to be done, of course, we're helping with that. But if all the reconciliations are handled 100% and you're confident, kind of like Dave was going over the eliminated entries between Goose Lake and the hospital, that's always going to be very helpful. And if we're in a situation where we have to provide some accounting assistance, fine. We're used to doing that. We know that smaller hospitals have deeper resources. So just keep in mind whenever we have to step in and help a little bit with those items, we're going to have time to audit.
Okay. Thank you. Any other questions anyone might have? Thank you.
Thank you, and goodbye.
Bye.
Goodbye. Interesting. Well, we've got more financial stuff. Oh, gosh, how am I going to follow that up? Well, this is, the audited financials are great, but they're from June 30th last year. Right. And that's a benchmark for us, but it's not what we currently do. So I always want to look at what currently is happening, what our trends are currently, and going forward, what we're doing. So, Ed, it's up to you.
Okay.
And I think too, a lot of the big adjustments you see in those financial statements from the audit was getting rid of old garbage, honestly. And I'd rather have them be right than pretty, you know? So,
Well, our big adjustment was the $797,000 we had to give back to Medicare.
it always seems like we'll have a $4 million pickup and we'll have a $4 million loss.
Right.
It's just like, it's frustrating sometimes. So this is the financial report for January 2021.
Technical assistance.
There it is. What's the old school way? Okay, patient count, 280 in acute, that's a decrease of 15 over the previous year. Clinics is where you see a bigger swing. 1986, a decrease of 114 over the previous year. This is due mostly to a COVID outbreak and Alturas Wellness and specialty clinics that all happened in that month.
But you can still see if you look at the year-to-date, the difference in 2022 versus 2021, it's almost not quite 10%, but close.
And
Or
then
5%.
other outpatient services, 5589, increase of 852 over the previous year is basically 776 more labs in that month, you know. Overall, for the month of January, I had 7,855 visits, an increase of 5,473 over the previous year. Large. Next slide, please. Gross patient charges for December was 4.23 million, an increase of 624,000 over last January, and right on budget. Thanks. For collections for January was 2.4 million, and decrease over last January of $15,000. But it should be noted that we had almost $400,000 that we collected in that month that did not post in that month because of the EDI software that I talked about last month. So this time in February, we put 4 or 5 people on it, so we won't have that issue, even if we have to do it manually. And these are big, like $150,000 payments that you have to go account by patient account, and make sure it's applied correctly.
Any sense of what February was like?
Oh yeah, February was 3.3 million. So it's gaining steam again.
That's a short month, too.
Yeah, I think I only had 17 or 18 business days or something. And I was trying to figure that out before we came in this meeting. So we our heads off to the builders for getting after it. Days cash on hand. So this is where we beat all our peers, which is awesome. It's kind of a accounting anomaly, but 103 days, 62 more than this time last year, for 2 extra months, and this is mostly because the PPP loan was forgiven. We unrestricted 5.1 million, and then we have a liability of 777,000. So they out of that 5.1 million, they forgave, I want to say 4.2 of it, leaving the 777 left. Next slide. Monthly net income. So for January, we had 4.24 gross revenue, less revenue deductions of 1.36. Out of that 1.36 revenue deduction, 1.1 million of it was contractual adjustments. So we're, like I said, it's going to spike a little bit for the first couple months. We start posting contractual adjustments when we post our payments. Less expenses of 3.4. Plus that 4.4 million in non-operating revenue expense.
So that's the highest net income month we've had in years and years and years.
And it's almost passed it over. And it's just if you have a forgiveness of debt, you gotta recognize it as a gain, you know, like me. So I was driving a truck next month. Next one. Prior to the adjustment. Through January year-to-date, the total revenue of 21.3 million, less operating expenses of 23.4, gave us plus that 5.8 million dollars, giving that surplus of 3.6. So, you know, expenses are right on budget. I mean, I'll take that any day of the week. Revenue, we still are getting after it and getting close that gap here in February or March.
Revenue deductions are quite high.
Contractual,
Well, the second line.
yeah, that's, well, 1.1 of it is actually contractual adjustments, and those are the best kind, because I mean, that just is what it is. But it's when we write them off for admin or something, that's the bad one. That means we dropped the ball. So. The next one, net margin, it's 4.5 million more than last year, so. Kind of
We expect that next month.
so I'm wondering how I'm gonna do it. Mary Ann told me she could get us there. And this is just a year-over-year 7-month trend. And you can see overall it's up 2.5 or 368 average, 16.2%. So in collections, there is a 5% rate increase, but overall we're comparing it in a pandemic. It's like not really. No, it's not anything to brag about. So next slide, please. The balance sheet, the biggest changes here were the obviously were the assets, liabilities going down. You see the $11.5 million increase down in the fund balance. That was about 3.4 million, and then you see the liabilities, the 4.3 million loan forgiveness, so the liabilities going down. That's all the excitement on there. Next slide is, so this is kind of almost the end result, pretty much of Whitley and CPSI and HRG and Cerner and what they were able to accomplish. And Whitley was able to reduce the AR by about $1 million at a cost to the district of $10,000 or 1%.
So what was Whitley?
They were basically taking when we didn't have the staff do it in house, so what they were doing was going through all the accounts, raking through them, and either writing them off or billing them if they could.
In CPSI.
In CPSI.
Which is our legacy system.
Yes, and that's what some of these big adjustments you see on the audit on it. Out of that $1 million, they collected, I don't say 300,000. So, for the Cerner, that project, that's all cash, that 2.2 million. Yeah, I don't think we wrote off anything. At a cost of 132,000, so 6%. So overall, the two projects simultaneously netted at 3.2 million. Cost the district about 4% of that. So not the results we wanted, but still successful nonetheless. Next slide. Oh, this was the AR dashboard. I just want to point out, it kind of hurts to look at on this screen, but you can see the AR balance is going down. The AR days are going down. All these numbers are trending in the right way. In February, will blow you away. And the reason that I'm showing this is because it hasn't gone down in like 16 or 17 months. So that's good. And that is all I had for slides for the Health District, but I did have a request for financing for the 3D mammogram. Needs a board vote of approval.
So a couple of things to keep in mind with this. I think I sent you the document. So when it's the obvious thing, this finance company, even though the board approved the purchase of the 3D mammogram a year ago when you approved the capital budget, you didn't specifically approve that piece of equipment. You purchased it last August. It was delivered and installed 2 weeks ago. Now it's up and running. To finance to finish the deal, we need to have a legal opinion signed off by our attorneys saying that you have authorized the purchase of this piece of equipment. They would not accept the approval of the capital budget which you did last year.
Has the price changed significantly?
The price was established prior to the budget. When you approved the budget, that's what the price was. We signed the contract in August, latter part of July. It was delivered all at the same thing that you said it was, told you it was going to be. And now in order to finalize that finance, this company needs to have board approval so that they can, the attorneys can give them a statement.
So this is this is financed by a lease on this?
Yes. Yes.
We could cause a real problem if we said no, huh?
I'd appreciate it if you did.
Could you refresh our memory, what is the name of this goes on?
Oh, it's a Hologic 3D mammogram,
But the financing company is First American.
little thing.
So you need a resolution from the board approving, setting up the financing for the purchase of this? So I'd like to so move that, if you can tell me what the name of the equipment is and then what the name of the finance company is.
So the name, as Ed said, it's the Hologic.
Hologic 3D mammogram, financed by First American.
I so move that we approve the finance on this equipment we've already purchased.
You're agreeing to purchase this. You have granted us authorization. They weren't sure that you actually granted authorization.
So the motion should be for granting authorization.
To make the purchase.
Does it have a dollar amount of purchase?
It's $330,686, I think, give or take. And
So I so move that we approve the purchase of this 3D mammogram for $396,000.
$330,000, and that's with a 7-year warranty and all that. Yeah, all the training. No big deal.
Been moved and seconded to accept the purchase of the 3D mammogram in the approximate amount of $330,000 and financing for First American. All those in favor?
Aye.
Passes unanimously.
So you want me to pass this out? Is that what you're saying?
Yeah, I'm saying that if we should do this now.
Yes.
Okay.
We've not encountered that scenario before.
We did, this company has asked this each year. Every time we have done something like this. I guess you need to see this. And you have a nice statute that revised management statement. They listed the law as well.
Did I get a revised?
Texted, or I sent you,
Oh, okay.
not audited, just the management.
Just the management. Okay, thank you.
So you wanted to go over the budget assumptions in the advisory committee before moving on?
No, what you're doing is, the budget assumptions are what allow us to prepare the budgets that will come to the budget committee.
So not on the agenda.
I failed to put it on the agenda,
Okay, so,
my mistake.
okay. Okay. So go ahead and run down the budget assumptions for us.
Sure. And basically it's just kind of, it mirrors a little bit of last year and it talks about some of the projects that have passed and what we're looking at coming up. The biggest part is really contractual adjustments, salaries and how the salaries are gonna look as well as our rates. Those are gonna be like the biggest, I think, things that are gonna make or break us in the upcoming year.
Notice you're putting a global master charge increase of 5%. Is that going to be sufficient to cover what we know inflation is now?
Contractually, with some of our contracts, it's 6%, I think we're limited to, without having to do a new contract. But I think we were having this discussion the other day, and I feel like we might need to go 10 or 15 to move the salaries up to inflation. Yeah, to keep everything in balance, and you want to have more up here than down here, so.
Well, because one of the things we've certainly seen in all hospitals are seeing is the rapid increase in travelers and that part of our expense, and I don't know if that's being factored into.
So I think the thing that you have to understand about preparing our budget estimates, we're gonna use these as tools as we gather our information from all the departments, and we put it together. almost always we find out we can't possibly make this work. So then we have to go back and adjust. And so these are our beginning assumptions. If we can't make this work, and we say 5% is this, and we know that cost of living is going higher than we would anticipate, that doesn't mean we can raise our rates higher than that. At the same time, we're also in the process of negotiating or renegotiating some of the payer contracts. Because the payers are clearly aware of what is happening.
Payers being insurance companies?
Yes, payer is an insurance company. So as Eric talked about, 70% of our business predominantly is Medicare and Medicaid, which is cost-based, but that other 30% is commercial. Those payers, we have contracts with them. They also know cost of living and they know the realities of what all organizations are facing. So we're in the process of, as Ed said, some of them have limitations on how much we can raise them. But if we negotiate those arrangements, we might be able to accommodate. And that's why this is to help. If you agree to these principles, you may disagree with them, but if you agree with them, that gives us a start. And that's really what we're asking. Unless you know something else, you say, no, we need to set it at a different number.
Well, anytime a budget is your best guess as to what's gonna happen in the future. If we knew what was gonna happen, then we wouldn't be guessing. Okay.
You're hoping that we'll make good guesses.
Yes.
So do you need a motion or?
Yes. We'd like that you approve the budget assumptions as part of, when we gave you the budget calendar back in January. Now we're giving you our budget assumptions based on what we think it will be. We'll prepare the budgets and have draft budgets available in May before the board or the budget committee will go through that. At that time, if the budget committee approves the budget that we've prepared, then it will come to the board in June for approval to be effective July 1. If the budget committee can't agree to the budget we've prepared on the first time, we have to have a second date because we have to have an approved budget from the budget committee recommending to the board for the June board meeting to be effective July. Those are statutes.
I'll let you take this one.
I'll move that we accept the budget assumptions for fiscal year 2022, 23. As given.
I second that.
Been moved and seconded to approve the budget assumptions for fiscal year 2022, 23 as presented. All those in favor?
Aye.
Okay, back on to Goose Lake Medical Services.
Oh, just one thing, I did send out to you an additional purchase we made that was budgeted. It's a big dollar amount, that's why I sent it to you. I'm not required to do that, but when we spend big ticket items, I think it's prudent for you to know.
What was this machine for?
As part of our nurse call system, the nurse call system that we currently have had is no longer, it's past its useful life, and it does not, it can't be serviced properly. So we went to our, we've been working on this for several years. We went to the main bed manufacturer that we were held on. They're the largest bed manufacturer for the United States hospitals. And they have a call light system. This integrates with those beds. So this allows us to have a much more, our safe, correct call light system. And that's why we're spending. And they're currently in the process of installing.
Thank you.
right, Lakeview Gardens, so for January, revenue was 258, expenses were 403, which resulted in a deficit of 145. And as we go through that too, there's, without the bed tax, but we still have some more work to do over there. And it's really the contract labor.
Contract labor went down. Finally.
More of those classes that cycle through with the CNA, it's gonna take time, but that's where we can make it. Over there, we have 10 contract CNAs, so at 60, 70 an hour, so. Yeah. Okay, Lake Health, medical supply for December, or January, had revenue, gross revenue of 50,000, that was the highest grossing month. And the highest netting of 4%.
What percent of anything's oxygen?
Pardon?
What percent of that 50 is oxygen or oxygen?
In excess of 80%. So significant amount. If the contracts that we have that we're working on with the payers for California go into effect, that number could be significantly higher.
10,000 surplus for the month, 63,000 for the year. And February was awesome for them too as well.
Good.
That's all I have.
Any questions? Okay. Moving on. Daily days, community health fair.
Daily days. So we had our first daily day committee meeting this last week. So the date for daily days is going to be the 25th of June. And due to space and restrictions, so we don't have to have any problems with mask mandates still in the hospital, we are going to move it this year to Memorial Hall downtown.
Okay.
So it'll be used in Memorial Hall as well as the lawn outside. Those have already been reserved. And next week, the road closure for Center Street that's adjacent to the lawn, we're asking for that to be closed between E and F Street. So that way we can expand into there and make sure that there's proper distancing and we have room for the vendors to come in.
That's the street between the Hereford building and the county building.
Okay. What's the date again?
June 25th. This year, it is the anniversary year of the 100th awarding of the Bernard Daly Scholarship, so it's a big year for the foundation. And this year, our theme that was voted on and chosen as celebrating a century of care. So we'll meet again for about every 3 weeks between now and then to get everything updated and get ready for it. But we are looking for food this year, like food trucks are coming in as well as the vendors, stuff like that.
Good. Excellent. Will be fun, as always. Okay. Quality date. Yeah.
Yes. Let me introduce myself. My name is Elena Ackland. I'm a Quality and Process Improvement Coordinator here. Already like 9 months. It's like
Let's hang up. Can you hang up?
Oh,
Well, you woke us up.
Can you hang it up with the red button?
sure. We need to share. Unfortunately, we need to oh, it's gone. Unfortunately, we need to share the screen to show some work being done. So let's start with the presentation. And then I will.
Elena, where do you come from and what is your background?
I came from Eastern Europe, small, very beautiful country named Belarus.
And what?
Belarus. And I have background in public health, and my second part of education is epidemiologist. So I'm a huge fan of data analytics, which I believe this is the future for us, to analyze our past, learn from our mistakes and move forward to understand how to improve and increase the quality of our service. So, next slide. Implementation of data analytics is a lifelong process, and it's like majorly going in 5 steps. Switching to another EHR last year, it was the hard process for the Lake Hills District. It brings some mistakes, some new process of improvement, but it's give us a huge amount of data in a better way because surgery is really great EHR. Can you move to the next slide? When I just started to work, we started to pay attention to the patient falls. I analyzed the data of our patient falls for the last 8 years. And in the last 8 years, we've been all these years lower than the Oregon state rate. And actually, back. Last year was our lowest year in 8 years. And even the amount of numbers of the falls was not the smallest, but it was an incredible job for Lake Hills District with the
Switching the zone.
with incredible rates of occupied bed days to keep us on the lowest rate. I think it's great. But what we did last year, and we keep doing this right now, you can press the next. We analyzed our patient falls by the quarters and by the each month. We analyzed the months for the last 8 years where we have the biggest amount of the falls. But we brought it information to acute department, to the nurses, where we need to pay attention. What is the highest risk for us? For the first time in 8 years, last December, we didn't have any falls. I think it's incredible. We also analyzed the time when the patient falls in our facility in the last 2 years. If you look at this like on the clock, it's showing that we have the biggest amount of falls in the morning, and at 3 p.m., and at midnight. But the patient falls, even in 8 years, it's only 130 falls. It's easy to analyze manually. That's why we will start to look into the program, which will help us to analyze the huge amount of data, like 10,000 records, which will help us to look at the situation right now without waiting a couple months to see result when we will have a time. Usually the quality measure, you start to pay attention when you're submitting this quality measure. We're working to bring the program which will help us to see it's monthly, weekly, depend on the measures, and we start to look at readmission problem in our facility.
What problem?
Readmission,
Readmission.
readmission,
You need this one?
close.
So do we have enough data to be valid, with the so few falls in such a small population?
I mean, the falls, patient falls, it's an incredible, and our numbers is low amount in the year, but to analyze and to see the patterns, that's why I was walking back to the 8 years, as far as I could get.
Okay.
To expand the
see it.
database, that
To expand the amount, so it's actually could be,
useful.
yeah, useful, yeah, it's the right word. We will try again, Julie. And I will share the screen with you. So we were looking to find a program which is gonna help us to visualize our data. And so far we stopped at a program called Power BI. So what is the readmission? If patient, discharged patient, coming back in the 30 days in our facility, am I right, Charlie, we don't have a money paid for this second visit. Readmission program.
We don't.
We don't. So we need to work on decrease this number and find out the reason why the patient coming back. So here we see our rate for readmission rate for the 2021 is 7%, which is lower than state about twice. State rate is 14, some hospitals have 28. The problem with readmission that any situation, it doesn't mean that the patient coming back with the same diagnosis back. Patient can be first time with a heart problem and second time coming in a hospital with a broken hip in 20 days. It's still called readmission. So some situation when patient coming back is out of our control, but something we can control. So now we can see, usually readmission we were able to see by the Medicare, just the Medicare, 4 months after the situation, when all the claims finalized and when the rates is going to us. Now we can see readmission rate by ourselves using our system. We can see, now we see readmission by any payers, but if we will choose to see just by Medicare, it's a different numbers. So the Power BI is flexible. It's changing how we need to see that and how it's important for us to see, not just by the everyone, but what we choose. We also analyze. We were able to analyze and see the situation by how the length of stay. So the 54% of our readmitted patient staying at the first admission in only 5 days. So flexible program helping us to understand the situation and analyze and see the reasons and try to understand the patterns, what we need to change.
The reasons why there's a readmission.
The reasons why, that's why we were analyzing the
One of the things about this Power BI tool, some of you that have used Excel have seen pivot tables.
Yeah.
This takes pivot tables way beyond anything you've ever seen.
It brings the
It drills down like you've never, it takes big data and really enables you to identify things like never before.
to see, to visualize without filtering a lot of columns. It's bring you everything. Like 10 of them. So it's, for example, first admission was circulatory system disease. It's showing that only 4 from these 10 was coming back with the same group and other patients, so it's helping. Now we're working to make it even more and more meaningful because it's gonna take a time. The Power BI was created mostly for financial analytics, so it's really hard to bring it to the healthcare system. And our EHR Cerner has also analytic tools, but they more like unified, and we're looking for reports which will be helpful for our facility and the question what we asking and want to know the answers. So this is a long process, but we're working on this and looking forward to increase the help from these tools and show the problems in the real time to our different departments to make the changes and increase our quality.
What Elena is not gonna show you is we can actually identify what patients they want.
Yes, I can show it to you, but if I wanna see what exactly this patient was, 10 patient, it's showing me the list of the patients. So it's not just hidden numbers. That's why I can't show it to you, but it's also showing us names, and we can go to the EHR server and verify and check those patients.
This is an extraordinary tool. And Elena's doing a great job at helping us begin to look at how do we change our behavior.
The improvement needs
Yeah.
going forward.
That's it.
It is very impressive.
We're looking forward to improve our service and increase the quality, which is already good. But there's no limit for perfection. Thank you very much.
Thank you.
Thank you, Elena. Thank you, Elena. Spasiba.
Oh, спасибо.
Next thing, quality update. Risk management.
You're right. First thing I want to talk to you about is some of our risk management adjustments we made here at the Health District.
John, you want to introduce yourself so everybody knows?
Apologies. My name is Sean Cosby. I'm the compliance and risk manager.
He's been here before.
Just making sure.
Okay.
One of the major changes that we've made recently, as you may be aware, Justin Westcott stepped down as our security manager, and I have taken over that position. We have also recently hired Scott Norby as our security supervisor. That allows us to have more security coverage throughout the day. We have our security personnel that work primarily on the night shift and on weekend shifts. With the addition of Mr. Norby, it gives myself and him backup if need be for any situation that may arise, or any liaison with law enforcement that needs to be handled during the day. Another major addition to our risk management, our screeners have been given training in assisting patients and the proper techniques for lifting and moving patients around. So they are able to transport the patients either by walking them with their walkers or with the provided wheelchairs that we have in the facility to their appointments from the front of the hospital, and if need be, back to their vehicles. The other item I have two documents here for your consideration and approval. I'm going to start with the Code of Conduct. This is a document you've seen and approved before. There are some minor changes to this document itself, one being the addition of our updated logo and revision of facilities that fall under this Code of Conduct, having to do with Lake Health Clinic, Lake Specialty Clinic, Home Health and Hospice, and the Alturas Health Clinic. The other addition to this document in particular is the summary of changes being added in. So anytime a change is made to this document moving forward, it will reflect in the document itself. Which leads to the second document for your consideration, being the Lake Health District Compliance Program. Myself and Rebecca worked on this rather extensively over the last 9-10 months to put together the most comprehensive and complete document that we could give you as far as a program of compliance for the health district. It details the rules that need to be followed, what my responsibilities are, what each employee's responsibilities are, rules and regulations that we need to follow both at the federal and state level, how we monitor that, any corrective actions that need to be made, and how those are handled. The format that you're looking at there is the same as what's provided in our policy stat program, which is where all of our district policies are kept. If the board chooses to accept the document as is, or both documents as is, the code of conduct will actually be added as a attachment to this policy in policy stats, so anybody can pull that particular piece up, as well as the letters of adoption. So if anybody has any questions about when it was adopted, so on and so forth, it can be pulled up in policy stat and shown to them immediately.
And this is given out to new employees as they arrive.
Yes,
Yes, sir.
it's part of the onboarding process.
Part of the handbook, right?
It's part of the onboarding process packet that they get, yeah.
Nice to have it all put together again.
Yes.
Are there any questions or comments? You guys are a tough crowd tonight. 2 hours of financials. No, he's just too prepared, you see, he's got us covered.
So this was last adopted by the board, it says in 2001.
The most recent change was the mission statement, which was adopted in 2004. Back when the board made that decision, our long-term care facility was still here in the hospital, not separated into Lakeview Gardens, and Alturas Health Clinic was still under Goose Lake Medical Services. So, as I said, those are some of the changes that were made to the code of conduct to reflect those changes as far as the renaming convention.
So are we looking down for a motion to approve
Yes,
these?
we are.
Well, that looks like a lot of hard work and thought has gone into this, so I move that we approve the updated code of conduct and Lake Health District Compliance Program.
Now, second. Okay. Discussion? We'll move that, it's been moved and seconded to accept the policies as presented for the code of conduct and Lake District Compliance Program. All those in favor?
Aye.
Aye. Thank you. Passes. Good job.
A lot of work went into that.
Okay.
The next part will go real quickly. Leanne, did you have anything that you'd like to say?
No, just here to observe. Thank you.
Okay. Dr. Chang's not here this evening, and we don't have any medical staff issues that need to be brought up. We certainly had a terrible tragedy, as you all know, with the death of Dr. Foster. But Dr. Chang will try to be here at the next board meeting. And Teresa Squires is not here. And Tori, because we have a very busy schedule and not enough staff, will be coming back later on tonight. And I said it would be okay that she not be present. Okay. The important part she was going to talk about is the installation of the Volte phone system and the bed calling system, so, which I told you about earlier.
That's ongoing now.
Yes. Right now, they're installing.
We should lead off the job.
Pardon?
HR is off the project as well.
We will go to HR in just a second.
Do you have anything you wanted to say, Rebecca, at all?
I was just gonna say that, of course, we're all very sorry, and deeply moved by the loss of Dr. Foster. We will have, a moment of silence tomorrow from noon, until 12:01. We're all going to gather out front if the weather is good, and back in the west wing if the weather isn't good. And then we're going to have a memorial planning committee next Thursday. It'll be at 1 o'clock. It's open to all employees. We're not ready to act on that because out of respect to the foster family, we're waiting until they've made their arrangements and they've given us the go-ahead to have any sort of memorial that the hospital employees select. But we're at least going to get in planning mode and be prepared for it. So it'll be good to do this and bring some sort of closure to some of the questions that we all have about what does everybody want to do. So, I have a new hire coming. I'm quite happy about coming on Monday, and we'll officially get rolling on Tuesday, and then I have one more coming in a couple of weeks. So,
Is that in your department?
yes. So right now it's just Kim and I struggling along. So I'll be glad to get some more folks on board. And that's it. Thank you.
Just a couple things that I'd like to talk about. Clearly, with so many things happening, it's always an interesting time. COVID has been an overwhelming issue for all of us, and we have been addressing that for the last 2 years. As I'm sure you probably know, as of originally the governor said as of March 31st or sooner, the mask mandate would end for places outside of the hospital. That's been revised based on the parameters that the governor's office had established, which was that when the number of inpatients dropped below 400, that would trigger not having the need for masking. The newest date is, I believe, March 11th, March 12th. But I looked at the report just before coming to the board meeting, and we're at 420 or 480 patients in hospitals in the entire state. So it has dropped dramatically. Good thing. We still have, we are believing that COVID will become an endemic issue rather than a pandemic type issue. So we still have lots of testing capability. The state has given us a great deal of it. We have it available in public health. We have testing kits available for employees, and we are giving out tests so that people can test rather than come to the hospital in the middle of the night and have the need to be tested. Testing is pretty good, so we would welcome the public to access those free COVID testing. One of the things that we have benefited from in the last month is that Oregon Health Authority has negotiated with FEMA to provide nurses to help in hospitals. There's currently roughly 5,000 nurses and allied health professionals in hospitals in this program. We currently here in Lakeview have, I believe it's 2 or 3 nurses on staff right now, and we expect tomorrow to get 4 more nurses for long-term care, a couple RNs and a couple LPNs. So that will help. Now that will go through the end of this month. After that, FEMA-supported assistance will end. We'll see what happens after that. But it's been a very big help because our census continues to be, as you saw the numbers, we've been impacted by it, and we have a continuing large number of patients in hospital.
So the ones that come in are travel nurses?
These are travel nurses. Yeah. They're coming from different places.
But FEMA's paying for it.
That's correct. Through the state of the Oregon Health Authority. But that won't end the end of the month. So we are trying to figure out how we handle going forward. A big part about thinking about COVID, and now what's gonna happen, what is life gonna be like after COVID? I would hope that you can help us think about what do we think our delivery system is going to be like post-COVID? Will it be like it was in 2019? Will we go back to that? Most are predicting it won't. We don't know exactly what that means, but this has certainly caused a great change in how we are delivering care. It is certainly harder for us to find people to work for us. Expectations are different. Employees everywhere, but especially here, have struggled. It's a lot of work. There's a lot of people feeling burned out. And so we've got to be thinking proactively, how are we going to work to create resilience in our employees, support our physicians, support our practitioners? There's a lot that we will have to look at in ways that we're going to try and address them. So as you're thinking about that, all suggestions are good. We will be having a strategic planning group for the board in the next 30 days. So Susie will be contacting you with the survey monkey to try and find a time that works, but probably a Monday or a Tuesday or maybe a Friday. Look at your calendar before it gets, well, Don, I don't know if you'll have the time, but
I'll make time.
we appreciate that. I know this is the time that you'll get really, really busy.
I'm cranky, but that's okay.
We'll work on that, because there are a lot of things that we want to talk about. Maybe we don't spend quite as much time as we have in the past, but just a touch base sort of thing. Physician recruitment is a continuing, ongoing process, no matter who we have here. I'm pleased to say that Chiago Mildy, who is a physician that came to visit us about a year ago. She did part of her rotation in her fellowship. So she's a family doctor who did a 4th year in OBGYN. She signed a contract and she'll be coming here, starting out 1 week, possibly once a month, but it may be once every other month. Part of the reason why it's hard to say is that she recently had a baby, and her husband is also in residency. So it's the logistics of organizing coming with the baby and having help and all those kind of things are ongoing.
Would she be working in the clinic then, or?
She will. And because of her work in OB, she will be scheduling to be here when Dr. Tan is not here, which enhances our OB capabilities and follow through. She'll also be working in our emergency room. So there are a lot of things that we can benefit from that. Dr. Jeff Chen, who has been coming here for the last quite year. He's an internist out of Washington. He has been working on an increased schedule of trying to come every 2 weeks. So that looks very promising, and if all goes well, Lisa's been working with him, Lisa Paquette, our new clinics director, and it looks like that will be happening. So that will again also enhance our capabilities in clinic and enable patients to be seen more thoroughly. Certainly with the loss of Dr. Foster, we're trying to figure how would we accommodate the needs of patients. We continue to look for other practitioners because, as always, no matter what we find, there's still more need. So we continue to keep doing it. Another exciting thing that will be happening, our EMS and other caregivers are working on May 17 and 18, having something like prom night. They're calling it prom night, but it's not really prom. It's an opportunity for 7th through 12th graders to see what happens when you drink and drive. so we're going to have an exciting experience for people to see a car accident and what happens. And so it's all to remind people, please don't do that on prom night or any other event. So it's a program that's been done in other places. Certainly, I think we've done this in the past, but it's pretty exciting to do. And it certainly opens up lots of people's eyes to, especially kids, the risks of driving while under the influence. Pretty good thing. God bless you. You've seen what Ed has and Blanca have developed for a revenue cycle plan. One of the things that's really happening is that's a positive thing. He's got the team focused and we're seeing some results that are really positive. And with Lisa in our clinics, we're seeing a lot of good step forward. So I'm certainly encouraged and appreciate all the hard work that Ed and his team are doing to get there. Essentially, that's all I have to say at this point. There's a lot of stuff going on.
All on the surface, not looking underneath.
A lot of that.
Okay. With that, we'll adjourn to executive session. Under ORS 192-660, document 2, document personnel, document C, medical staff, document E, real estate, and H, legal. And we'll have the board remain. Charlie.
Did we get the checks